I'd just like to give a very brief introduction firstly to both Penny and myself. My name is Andrew Searles. I head up the Health Economics team here at Hunter Medical Research Institute, and my colleague Penny Reeves also helps to run the Health Economics team here at HMRI. And in 2018, we were engaged by the Australian Health Research Alliance to undertake one of their rapid translation projects. And the particular project that we were asked to look at is how could we improve the local level evaluation of healthcare in Australia. We did this particular project with a raft of expertise from around the country. Apart from Penny and myself, it included Marie Gleeson, Christine Jorm, Stephen Leader, Jonathan Carnan, Harriet Hiscock, and Helen Ferris, and Michael Daly. This team were an expert panel that not only oversaw the project that we undertook, but they also provided guidance to a framework that we developed. So Penny, could I hand over to you to start the first part of the presentation?
Thanks, Andrew. So we're just going to talk about the background and some context for the project, and then Andrew is going to discuss the findings and what's next. So just some definitions so you can understand where we're coming from. So health technologies, for the purposes of this project, had quite a broad definition. So apart from the usual medicines and pharmaceuticals, we were talking about models of care, health policies, tests, procedures and diagnostics, health administration, and medicines and devices. But for the purposes of this project, and given that evaluation at the national level encompasses devices and medicines really well, we wanted to focus on these other types of technologies that exist within local health services. So what do we mean by local level? So for the purposes of the project, we were interested in talking to health services that could be at hospital level or regional health services, districts, where health services are being delivered. And the reason for the focus on local level was because we wanted to understand local context and understand why that's different in local health service decision making, different disease burdens, demography, and socioeconomic variables. So for example, here in the Hunter, New England area, we have quite a wide-ranging populations. We've got metro, we've got rural, and we've got remote, and making health services decisions in the health service across all of those different populations is important. So why do we need more evidence-based decisions in healthcare? Well, there's a few reasons. Essentially looking at sustainability of healthcare expenditure. So at the moment in Australia and in other Western countries, spending on health is greater than the growth in gross domestic product, in how much a country is producing. So we know there are existing inefficiencies and inequities in health spending, and we don't always know that our spending choices are returning value, and it's important to understand that. We understand that there is significant wasted expenditure in health. So estimates from the Productivity Commission and AHW suggest that out of the $180 billion spent in healthcare per year, around $36 billion of that is wasted. And so it was the team's view that looking at local level decision making and evaluation would allow us to look at ways to mitigate that wastage. So the problem, so while some healthcare technologies, as I said before, medicines and devices, for example, are evaluated really well with world-class decision-making processes at the national level, that's not translated at the local level, and many technologies such as models of care are not assessed for effectiveness, and they're certainly not assessed for cost effectiveness or affordability given local context. So we were guided by some advice that came out of the Productivity Commission a few years back, where government subsidised healthcare treatments that have not been formally assessed for clinical and cost effectiveness. So we were looking at how we could impact that. So some specific comments from the health services that we spoke to when we were undertaking the project, emphasising why it's important to take into account local context. So, for example, too often a technology or a model of care is being seen as effective in one jurisdiction and is just adopted in another without taking account of that local context. And decision makers ask for evidence, but the standard of evidence provided is variable. So we spoke to some health services about the types of evidence that they are comfortable informing their decision making, and the range is quite considerable. So what we found was that existing centralised models work well for those nationally provided and funded technologies, but where there's local decision making around models of care, there isn't the same rigorous decision making process. So the solution, as far as we saw it, was that improving local level evaluation would assist in making better decision making and ultimately result in more value delivered for healthcare expenditure at the local level. So Andrew's going to talk about the specifics of the project.
Terrific. So thank you very much, Penny. So in this slide, I'm going to give you just a very high-level overview of the way that we actually approached the project, and starting with the aims that were provided by AHRAA, the Australian Health Research Alliance. So firstly, we were asked to review and report the evidence on the models for evaluation, gaps in the evaluation that was undertaken, healthcare evaluation that was undertaken in Australia, and thirdly, to identify strategies that could be used to improve evaluation in this country. The second aim we were asked to address was to come up with a framework that would improve evaluation and implementation in Australia. So the way that we did this was firstly to undertake a targeted literature review. So we did this, as I mentioned earlier, this was a rapid translation project. So we had 12 months from start to beginning. So we were doing the literature review at the same time as we were conducting consultations around the country. So we spoke with health services across Australia in each state and territory. And also at the same time, we embarked on a process of coming up with a framework to improve evaluation and implementation. And that was designed with the help of our expert panel, and the members of that panel were on our very first slide, and they're all authors of our report, and they're all authors of this presentation. So in terms of the outputs from the literature review and the consultations, we identified models for evaluation, gaps in the evaluation of healthcare in Australia, but also some strategies to improve evaluation. And from our framework design, we came up with two levels of the framework. And one was a very high level, one single page identification of what this framework might look like. And the second component of this project was to come up with a very detailed framework that went down into, I took deep dives into all the various aspects of the framework as to what it might look like if this was to be rolled out in a particular health service. In terms of the outcomes from our work, we came up with a report of the findings, which was released last year and presented at the NHMRC, and it's just recently been made available on the New South Wales Regional Health Partners website. We also, as part of this project, identified 10 core problems associated with evaluation in Australia. We also identified actions for each of these problems. In terms of the framework, as I mentioned earlier, we came up with both a high-level overview of what the framework would look like, but we also provided the detail that went with that. And we came up with 4 national recommendations. So just at the outset, a comment I would like to make here, and we're going to repeat this a couple of times in the remainder of the presentation, is that what we were talking about is actually having a set of national guidelines in terms of evaluation, but the execution of that evaluation is done mostly at the local level. And hopefully, as we go through the remainder of the presentation, that will become clear as to the message that we're trying to get across. In terms of what I'm going to present today, I'm going to identify the 10 core problems. I'm going to show you the high-level framework, and I'm going to reveal the 4 national recommendations that came out of our project. So in terms of the 10 core problems, one of the core problems that came up through the consultations, but also in the literature, is that there is no agreed framework for evaluation or implementation in Australia. A second problem is that there is inconsistent access to evaluation resources. Some health services told us, because of their affiliations with medical research institutes or universities, that they had reasonably good access to evaluation resources, but others said that they had no such relationships and therefore they had a gap in their ability to do evaluation. There was also inconsistent ways in introducing new technology. Sometimes you were told it was through opinion of maybe senior clinicians and sometimes politicians. Other times, the introduction of new technology was based on evidence, and that's of course as it should be. But we were given examples of where new pieces of technology were brought in because senior people within the service thought it was a good technology to be brought in, and as a consequence, health services had to do their best to introduce that technology, even though there was at times a lack of evidence in terms of its effectiveness and cost effectiveness. Another problem is that low-value care is still a problem in Australia. The issues that were raised with us is how to identify it, how to evaluate it, and then how to implement policies to disinvest from low-value care. A fifth problem was around stakeholder engagement, and this is something that we don't do particularly well in Australia, and we rarely do it when we're evaluating a new technology or a new model of care. The sixth problem was that the community knows very little about the relationship between evaluation in healthcare and decision making. And the problem here is, of course, that it opens doorways for other non-evidence-based pathways to influence decisions. The seventh problem is that there is insufficient capacity building in evaluation and implementation. So the issue that we're raising here is that many of the people that come through as potential evaluators for health services are not quite used to working in an environment where the data that might be available for some national or even state problems is not readily available at the local level. The eighth problem was around funding for evaluation. And some of the issues that we were told about here is that some health services did have the opportunity to build up their evaluation and implementation staff profile and expertise in this area, but because